What's the reason why we are talking about speckle tracking? We know that fetal cardiac dysfunction often appears subclinically, and therefore it might be missed or remains undetected by conventional methods like Doppler ultrasound or CTG or things like that. Now, to improve fetal cardiac monitoring, new tools like speckle tracking are available in the meantime, and I would like to show you some clinical situations in which we can implement these tools. I would like to start with this clip of a fetal heart. It's a normal fetal heart, you have to believe me. It's a normal fetal heart of an obese mother, BMI 35.4. With mother has gestational diabetes and in 32 weeks of gestation. Now, fetal biometry, you can see estimated fetal weight here is 88 centile, normal fetal Doppler parameters. And now, I mean, we have a normal CTG at this gestational age, and when we have a closer look on the way the myocardium is moving, then we can recognize by speckle tracking that there is a reduced movement expressed by a reduced global longitudinal peak systolic strain. Now, this might be a hint or an indication for cardiac remodeling in gestational diabetes as a part of so-called fetal programming. We all know about that, and with the knowledge of that, we should have the aim of an early detection of cardiac dysfunction and the prediction of cardiovascular risk constellation. Now, the point is, speckle tracking, what is it exactly? Just a short reminder. It's a non-Doppler angle-independent, more or less angle-independent technique which offers the dynamic investigation of the fetal heart by tracking the myocardium within one cardiac cycle. As you can see here in this table, there are quite a lot of vendor-specific software solutions available, and we want to concentrate today on especially the one here available by Canon and the one we are in our department working for several years now. So, speckle tracking, how can we get to all these results? I want to show it here. 24 weeks of gestation. The basis of your acquisition is obviously always a four-chamber view. We think that it might be a good idea to get it either from a basal or from an apical four-chamber view. This is not always the part, or it's not always the case, as you could see here on this congress, because there are colleagues who use a transverse view. We think, and this is our experience, we think when you think about the technical point, it's the way that you have in this situation not the problem of a poorer lateral resolution. So because you want to get to know the longitudinal peak systolic strain, which is expressed, or it's an expression of the contraction. That means shortening and lengthening of the myocardium, and therefore you need a good axial resolution, and you will not lose information by a poorer lateral resolution. So, yeah, for chamber view, as you can see here, now we have the problem, because this is a tool which is normally based on experience in the adult echocardiography, we have the problem of a missing ECG. So we cannot get the ECG of the fetus. What we have to do is to get one cardiac cycle we have to crop the cycle when after you have saved it on your ultrasound machine. As you can see here, it is cropped to 1 cardiac cycle, and then the next step would be, and this just takes only maybe half a minute. You trace the endocardial border so that you get fulfilled all the whole ventricle, and the system will then semi-automatically detect the myocardium, and at the end you get your quick results here. You can see the dynamic tracking here on the left. Yeah, it's there you can prove that your tracing was quite a good one. Sometimes you will not get it from the first time on, so you can here prove it. And on the right side, you get all the longitudinal strain during the cardiac cycle. And when you want to know your longitudinal strain value, you can see it down here, -22%, which is within the normal range. Now, when you think about the fact that it is something which comes from adult echocardiography, then it's we have to think about the fact that in a fetal situation we have much higher heart rates. So that means, on the other hand, our temporal resolution is it's worse than in the adult situation. So we have to think about the frame rate when we do our data acquisition, and this is one of the part we proved in the past. Yeah, we first checked the way your video loops in your clinical department or in your private practice, they are saved with 30 frames or either 60 frames per second. And we checked, is there a difference between both frame rates, and we could detect that there is no difference between those two frame rates. They are very low, obviously. So in the next step, we had a look at the original frame rate. This is the frame rate your ultrasound machine offers you. It's not the one you get at the end when you are saving your clip. And here we could see that there is definitely a difference between your very low frame rate on the one hand and your acoustic frame rate or original frame rate on the other hand. Yeah, just to show you that this is something which obviously works here. One clip for the left ventricle. It's here -17.5%. This is a bit lower than the average, which is about 19%, for example. And the next one is of the right side, the right ventricle. Here, -19.2%. In that case, as you can see here, our distribution of reference values we got. Now, as I said, frame rates, just to show you that there is definitely that it is a point where we have to think about. This is a fetal heart, a normal fetal heart. What do you think? What kind of gestational age do we have here? I'm asking that because we know all that in higher gestational ages we have the problem that our scan range must be quite wide, which automatically reduces the frame rate. This is yeah, it's 38 weeks. 38 weeks. We have here 44 frames per second. You can see global longitudinal strain of 20.7%. And now we have 128 frames per second. It's the same patient. Here, minus 20.3%. Actually, not. It's quite similar. When we get an example where the difference is much wider, here 85 frames per second. On the one hand, you can see here minus 17.5% for the global longitudinal peak systolic strain, and here 205 frames per second. This is in 27th week of gestation. Yeah, you can see here minus 19.7%. So this is something which should show you that within one patient we have to think about the comparison of different longitudinal peak systolic strain values. Different vendors, different frame rates. There is a different, even if someone says there is no difference, there is a difference, because when you think about higher frame rates, this analysis is based on vectors, and with higher frame rates, your vectors will get smaller, and at the end, the global longitudinal strain values will rise. So just to keep in mind that when we are comparing these values, we have to look at the frame rates. Now I would like to come to clinical applications. Maternal diabetes, we know already that from epidemiological data confirming the relationship between maternal diabetes in pregnancy and an increased risk for cardiovascular diseases postnatally. We performed a study. You can see here we had a control group of 79 fetuses and 82 fetuses with diabetes. And the global longitudinal strain for the left ventricle and for the right ventricle in both groups were comparable. When you just check between controls and diabetic patients. When we performed a subgroup analysis and checked, okay, controls versus diabetes type 1 and 2, insulin dependent and non-insulin dependent gestational diabetes, then we could see that there was only in the group of insulin-dependent gestational diabetes in the third trimester where the global longitudinal strain values were a bit slightly raised up against the normal situation, because we know from the normal values that with ongoing pregnancy and maturation of the myocardium, the strain values will go down. So how can you interpret this information? These are obviously data from Germany. We have changed our diabetes screening a few years ago. It's quite a strict one. The patients are screened between 24 and 28 weeks. So it's actually the point that we don't see these quite horrible diabetic patients with all the following problems, and I think we can interpret this as a kind of winning situations that this screening works in Germany. Now, coming from the maternal diabetes to a cardiac situation, hypoplastic left heart, we know that the outcome of hypoplastic left heart fetuses regarding the long-term morbidity and mortality is quite depending on the right ventricular function, because the right ventricle will get the systemic ventricle postnatally. And here you can see a fetus in 36 weeks of gestation. It's a hypoplastic left heart subgroup mitral stenosis aortic atresia. In this clip, it's a bit a pity that you cannot see the clearly the endocardial fibroelastosis, but there is obviously one, and when you get or perform your strain analysis, you can see that the global longitudinal peak systolic strain here is going down with minus 13.3%. Even when these pictures are performed or saved with the older version of the this software solution, I want to show it to you here. 27 weeks with a classical hypoplastic left heart, mitral atresia, aortic atresia. Here, interestingly, the global longitudinal strain. It's the white graph here with a normal value, like the one here in 38 weeks, also classical one, minus 18%. First, it's quite interesting, and we performed a retrospective study with different kind of subgroups of hypoplastic left heart, and as you can see here, we have a hypoplastic left heart with an open foramen ovale, a group of foramen ovale restriction, and gestational age match controls. And as you can see here, the group of foramen ovale with a which is patent, and the control groups, they show nearly they show a reduced longitudinal strain. The group here with a restrictive foramen ovale, which is more or less the same like the control group. This is due to the small number of patients. You can see here only eight patients in that group. Interestingly, here the subgroup analysis of hypoplastic left heart with endocardial fibroelastosis compared to the control group. Here it's a very significant decrease in your global longitudinal strain. You can see here minus 12 versus minus 16.8%. Now, when we know about different or by already published papers that we have prenatally an impaired diastolic function, we have this is we can discuss about that in impaired systolic function, and we know about the postnatal problems. Then we should keep in mind that more or less the aim of our cardiac investigation should be that we one day will be able to prenatally predict postnatal or postoperative outcome by investigation of cardiac function. A next example I would like to give is the one here by this case. It's an interesting one. A patient who was referred to our department, I think, at the end of 20 weeks of gestation, and the local gynecologist said, "Yeah, it's a bit strange because in the four-chamber view, this you see, yeah. What do you see? What do you think about that?" You see this this very hyperechogenic interventricular septum. So what could that be? What do you think about that? What would be your next step when this patient comes to you? Pardon? Tissue Doppler. Okay. I'm sorry we didn't that. Mm-hmm. Normal frequency. Yeah, we did that. No, normal. Any other comments? Pardon? Brain? For infection. Calcification, yeah, because you have in mind infection. Yeah. So just morphological, yeah, yeah. Completely normal, yeah. Torch screening was negative. Patient upset. So we got our pediatric cardiologist. He said, I don't know what it is. Patient still upset. So we said, okay, we have got this tool. We want to see. I mean, obviously, it looks like an endocardial fibrinolystosis. Yeah, that's the reason why we first of all looked just for the morphology, and what we could see is that within the segmental analysis, there was no difference to a normal heart. So at the end, the contraction of this heart is totally normal, and we try to calm the patient down and said, okay, postnatal, we offer another echocardiography. So you can see here 23% of global longitudinal peak systolic strain as an average, although there's this very interesting echogenic structure. I mean, this is this tool of Speckle tracking, and when you have a look at the papers which are already have been published, it's something which is only or mainly based on investigations of the second and third trimester. Obviously, we thought, okay, why not trying to use it in the first trimester, not directly with a clinical implication of that, because when you have a new tool, sometimes it is the way that you try to measure something and then have a look at special situations if there's something new you can detect. So we just try to get to use this because with the possibility of very high frame rates, in this case you can see again here 195 frames per second. You have to keep in mind this is at the beginning of 30 weeks of gestation. When you go home and within the next days when you sit in front of your ultrasound machine, try to get with your cardiac setup this high frame rates in that gestational age. We said, okay, we'll try it in first trimester, and I want to show you how this will look like. 13 weeks of gestation, and here, obviously, we said, okay, a differentiation between left and right ventricle. At the moment, we don't think that this makes a lot of sense. So we thought about a thing like a biventricular strain, just to look at the lateral free left and right wall. And when you look at the when you look at the strain, minus 17.1, it's quite comparable to the one we get in the third and second trimester. So, but this is an ongoing part of this tool, and I hope that we, for example, next year will get some interesting results of that. I would like to come back to my first slide. Now, regarding the aspect of fetal programming and cardiac remodeling, fetal cardiac function should be investigated in a certain kind of fetal or maternal pathologies. I think it's a very promising tool. I'm not sure that we can predict whether this young boy of this fetal cardiac loop will end like this or end like that. But maybe we can help in this situation to get a better understanding of fetal cardiovascular deformation, and I thank you for your attention.